Welcome, colleagues. Colleagues, welcome to the Global Coalition to Address Synthetic Drug Threats, Sub-Working Group 2.2, Information Sharing, Interagency Collaboration, and Policy Formulation. This is the December session of the West Group and our last meeting for today. My name is Brian Morales from the U.S. Department of State, and I will be providing a couple of administrative announcements. First, on civil society engagement. As some of you may know, in the July 2023 Ministerial Declaration on Accelerating and Strengthening the Global Response to Synthetic Drugs, participating governments expressed their commitment to take into account input from civil society and coalition objectives. Since then, we initiated these sub-working group meetings and by consensus decided that we should have these only within governments and international organizations. So we've established this alternative process to engage civil society organizations, and they will be posted on the Global Coalition website in the coming weeks. But in short, first, national dialogues of governments will be encouraged, where national governments convene their civil society organizations. The United States will do so at the end of January, bringing together U.S. civil society organizations through the White House Office of National Drug Control Policy. A readout of that meeting will be posted on the coalition website. Secondly, we will have the Vienna NGO Committee organize a global civil society forum, and that will be during the month of January. Again, that will also be posted on the website. And if you have any national dialogues, we encourage you to create your own and also to share with us that information so we can post it on the website. Third, we will have an exchange of experiences on the Global Coalition website, inviting recordings and documents from civil society organizations from January to April. If civil society organizations have recommendations for the Global Coalition, we will also invite and collect those to be posted between January to April. And from April to July, we will be inviting civil society organizations to share achievements, which we will also share on the coalition website. Also, at the discretion of co-chairs, civil society representatives may be invited to present at specific sub-working group meetings. And so we will be discussing that with co-chairs and determining for which sub-working groups we would like to make that available. Another announcement, the Global Coalition website launched last month. The address is globalcoalition.us. We encourage you to visit that website. On the website, under the tab for sub-working groups, you will find a dedicated page for this sub-working group where you will be able to see the agendas for the upcoming meetings, and they will be updated in real time. So you'll know the updates as we know them. Also, you will be able to access past recordings if you've missed any of the sessions for both the East and the West groups. We also invite you to submit videos for the website. So if you would like to record your own content, 15, 20 minutes, as long as you wish, or documents, please also send those to us, and we will be posting those on the website. So with that, I'm going to stop sharing my screen, and I will turn it over to our co-chairs for today's meeting, Clara Mal and Jenny Fagua. Over to you all. Thank you so much.
Thank you, Brian, and good to see everybody, and really helpful to see, how we'll start to have that platform for further exchange of information outside of these meetings. So we have two presentations today, and we're going to begin with Anselme Sanou from the UNODC-WHO facility survey. Are you there, Anselme? And do you have slides?
Hey, Claire. Go ahead, Cyril.
I'm sorry, the presentation is going to be recorded, and the recording is coming up. Stand by, please.
Thanks.
Distinguished colleagues and delegates, good morning, good afternoon, good evening in your respective countries. I am Anselme Sanou from the UNODC Regional Office for West and Central Africa, and it is a great pleasure for me to present our work on substance use disorder treatment facility survey as a tool to support planning and monitoring of a responsive treatment system. The UNODC-WHO international standard for the treatment of drug use disorders were developed by the UNODC and WHO based on a strong international policy mandate and based on existing guidance. It has become an internationally recognized reference point, providing a public health framework for the development of a drug treatment system and evidence-based drug treatment services. The facility survey, together with the international standard for the treatment of drug use disorders, the treatment demand indicator, and the UNODC treatment quality assurance tool, form a basic suggested package for treatment planning and monitoring. The facility survey is a survey which is conducted to map the treatment of substance use disorders in a country, measuring the demand for treatment of substance use disorders is vital for monitoring changes in the pattern of drug use in the community and in planning a responsive treatment system. The survey has been developed in the framework of the UNODC-WHO program on drug treatment, drug dependence treatment and care. The goal of the facility survey is to map the treatment of substance use disorders in a country or in a region to support planning of a responsive treatment system for treatment of drug use disorders, especially in absence of more comprehensive drug information system. The facility survey consists of several sections, such as details of the survey correspondence and for the general public, the description of the treatment facility and the treatment offered, the number of people treated, and also the treatment capacity, including the buildings and the staffing. It is very easy to administer and is available in more than 10 languages. It is possible to do the facility as a paper-based data collection or an online data collection using the drug monitoring platform. It is self-administered. It is a self-administered questionnaire. It needs input from relevant substance use disorder treatment service providers, including primary health care, specialized treatment center, mental health clinics in a city, in a region, or in the entire country. The facility survey has been implemented in several countries in Europe, in Africa, in America, and in Asia. It was already completed in more than 22 countries. It has an important tool for treatment planning in line with the international standard for the treatment of drug use disorders, and is especially useful in the absence of other routine data collection systems on treatment demand, drug use, service accessibility, and in this way can also play a role in improving the nationally available data that will be included in higher level data collection exercises, such as the annual report questionnaire. Some completed national and regional reports are available in our website. For example, the one from Southeast Asia, from Latin America and the Caribbean, from West African Francophone countries, another one from Central Asia is coming up. This is an example of the West African facility survey we report. In the facility survey, you can see a limited access to drug treatment. In yellow, for example, you can see the regions in each of the different countries, 9 countries in total, where we don't have treatment facilities. And in red, you have regions in the different countries where you have treatment facilities. In a way, Facility surveys can be used to generate a consolidated analysis of substance use disorders treatment accessibility, affordability, and diversity, as well as the geographical distribution, the type of facilities available, the services provided, the resources available, and the consolidated patient information. The facility surveys are important steps to understand the capacity of treatment systems, assess their quality, and plan for improvement in line with the international standards. The facility survey supports the preparation of the key quality standards for the appraisal of drug treatment services, which include effective management of the service, individualized patient-centered treatment and care, timely access to treatment-based interventions, and promotion of patient health, safety, and human rights. For more information, we have our website, which is available. Feel free to contact us if you have some questions or need more clarifications. Thank you very much.
And you are welcome to proceed.
Gracias, Dr. Sanou, por tu presentación.
Thank you,
Esperamos.
Dr. Sanou, for your presentation. We hope that at the end of our session, we were able to have some questions by participants in this working group. So next, we will give the floor to Professor Parry, the Director of the Mental Health, Alcohol, Substance Abuse, and Tobacco Research Unit in South Africa. Dr. Parry, the floor is yours.
Thank you very much. I'm just loading my screen. Can you see it?
We can see a screen. Go ahead, please.
Thank you. I have 13 slides, but I won't comment on everything in the slides. So the topic of my presentation is, let's just move this out the way, building, sustaining, and growing drug epidemiology networks in Africa, just as an example, a 25-year perspective with particular emphasis on the SWG, which is the South African surveillance system, and SENDU, which is a Southern African surveillance system, which is no longer operating. Move the slide. Okay, I want to talk about the birthing of SWG, and I'll explain what SWG refers to. So it all started with an invitation I had to attend a meeting of the International Epidemiology Network on Drug Use in Vienna in May 1995. And that's a picture of Zili Sloboda on the bottom right, who was one of the leaders of this initial meeting. And I was asked to present on drug abuse in South Africa, and it exposed me to the work of other epi networks, such as the one by the Pompidou Group and the US Community Epidemiology Working Group on drug use. It connected me with key players working in this area, and it exposed me to the methodological aspects of epidemiology networks. And it also led to a 3-week consultation at what was then the UNODC-WHO on the International Drug Abuse Assessment System, which was a predecessor of the Annual Reports Questionnaire. And I also got invited to the US Community Epidemiology Workgroup meetings every June after that. And we had ad hoc meetings of this international network. And this meeting led me to establish the South African Community Epidemiology Network on Drug Use, which is SWG. So what it is, it's been in operation now since 1996. It's a network to collect data on alcohol and drug abuse in South Africa. And its objectives are listed on the left. It's to identify changes in the nature and extent of alcohol and other drug use and emerging problems. particularly to identify changes in negative consequences associated with substance use, to inform policy and planning and advocacy, to support networks of local role players, to stimulate research that's identified as being important to identify, so that we can find out what's going on in the drug and alcohol space. And it's also to facilitate our full participation in international fora and to help us to fill in the annual reports questionnaire. So the current system really has 3 data sources. It's collecting data from all 9 provinces in South Africa, and it collects the data on a 6-monthly basis and collates it 6 monthly. So the core elements currently of the data system are treatment demand data, where we have information, demographic information. We have information collected from people coming to these 100 treatment centers around the country on the primary and secondary drugs of abuse, the mode of use. Are they injecting, smoking, ingesting in other ways? Have the people had prior treatment, or is it a first treatment episode? Who's referred them to treatment? Questions around, have they been tested for HIV? Because we have a strong relationship between drug use and alcohol use and HIV. And also we ask questions about different comorbidities. We also link that with what's called a service quality measure. It's not only important to find out why people are going to treatment, but also we collect data on their treatment experience, quality of services given. And there's also recently we've added components around community harm reduction services. The exposure of people to various forms of harm reduction, needle exchange programs, other kinds of methadone treatment, and so forth. So the sequence of data collection, there's every 6 months, data is collected from these different sources, the treatment centers, from community harm reduction program initiatives. It's collated, particularly at the treatment center data. It's also collated in terms of the harm reduction services provided. It's the data is captured, there's an analysis phase, and there's a report back every 6 months in different parts of the country. We also allow for presentations additional presentations, maybe there's been a household survey or some other form of data collection that's important. So not just the data on the treatment system, the service quality, and also the harm reduction, but other data sources that happen to be available at the time. Past research, we've collected data from other sources that you can see there on the left. So psychiatric data, police arrest and seizure data, but we're finding that hard to get at the moment, but we're planning to bring that back in. We've got data on mortuaries, arrestee data, trauma unit studies, and sometimes we've had data on wastewater surveillance as well, but these are not every 6 months. So the key features of that support the Secendo data system are stable leadership in a stable institution. My unit has been collecting this data. We have funding from the government at the South African Medical Research Council, so it's in a stable environment that's got the resources to manage this. We initially had strong external support from the UN, from WHO, and also particularly, you can see a picture at the bottom. From the bottom left there, you'll see Nick Kozel, who was involved for many years at the National Institute on Drug Abuse in the US and managed the US Community Epidemiology Work Group on Drug Use. Initially, we got funding from the World Health Organization, but now we have local funding from our Department of Health and Social Development. What also sustains it is 6 monthly meetings. We have regular report backs in different formats, reporting short reports, longer reports. We adapt to change. Now we're collecting data online. It's linked to other initiatives such as the other projects. Graduate training is linked to it. The service quality measures project I've mentioned, harm reduction, so forth. And it feeds into our reporting to the annual reports questionnaire every year. Then we led to it, we were asked in 2000 to help write a proposal to the Southern African Development Community, and we rolled out Secendo from the 9 provinces in South Africa to 13 other countries. You can see them listed there in terms of the order at which they were rolled out and the date at rolling them out. We provided training supported by the UN and SADC. It was rolled out sequentially. So we started with, I think, the easiest countries, and we ended up with countries that were more complex because of what was going on at the time. The last 2 countries were the Democratic Republic of the Congo and Angola. Main data sources across the countries were treatment demand data, police arrest and seizure data, and psychiatric hospital data. This was largely secondary data, although we introduced forms to collect the treatment data, as I described earlier. We had funding from the European Union through the Southern African Development Community for funding country report preparation and funding to attend 6 monthly meetings. So I think that was key. All the countries came every 6 months together, and those that had been rolled out presented their data, and other countries could then see how the data was collected and being presented. We also married it at some points in time to training for countries in completing the annual reports questionnaire. And we released 6 monthly reports, country reports, and an overall report for those countries that were on board at the time. And we ended up with 14 countries providing data. One of the things we do, and I'm not going to go through this in any detail, is as the data are reported by countries, that's the data from specialist treatment centers, if they have it, the data from the police arrests and seizures, and also from the psychiatric hospitals, is we try to identify implications for policy. We also identify, as the data are presented in PowerPoint presentations, what are the issues that are emerging that we want to watch in the next 6 months, so issues to monitor, and also areas where we think further more intensive research should be carried out. That's not to say we necessarily had the funding to carry out the research, but we at least put it out there that these are important topics needing further research. The successes of the Secendo, the project in the 14 Southern African countries, was we launched the networks following technical support visits of 1 week in each country. We had 6 multi-country report back meetings in different countries, and you can see the dates held there in the second bullets. We prepared various technical support documents on how to collect the data in the psychiatric hospitals, the format for police arrest and seizure data, the treatment data, and so forth. And we translated them into French and Portuguese, and we had various written outputs, including 10 6-monthly reports covering data across the countries that were on board at the time. The project unfortunately formally ended when the EU funding ended, but some of the countries continued to collect data. There was, we had at the end, we had an internal process evaluation, and the report was dated May 2005. So obviously it's outdated, but I think this model could be replicated if there was a need to roll it out again. I don't think the model was not successful. It was the funding that ran out. What worked, I think, was ongoing technical support, very important. The agreement on core indicators and data sources, establishing within country epidemiological networks and country focal points. We collected data at most sites. A couple had challenges. We had regular 6-monthly meetings. It was linked to political structures. So when we had our 6-monthly epidemiology meetings, they were held alongside meetings of political counterparts who were looking at what to do about drug abuse in the country, and we would present the epidemiological data in those forums. There was information dissemination. There was some funding, moderate level of funding. So that's what worked. There were challenges, as you can see there. There were language differences. It was quite costly to have interpreters. Communications challenges in some countries. They had challenges with internet, but I think those difficulties have probably largely been addressed now in the time that's passed. There was a lack of commitment from some of the political principals to contribute funding to the project, which was the intention all along. Instability in some countries. You can read them there. I won't go into all of them now. We're running out of time. There were recommendations given in that report on how to strengthen the project around funding, technical support, how to expand data sources, and particularly to improve the quality of data. So this, like the ARQ, this is something that was rolled out with the intention of improving quality over time. So I think that's a model that can work. You don't go for the best, the gold standard you start small and you improve over time. We had some comments on how to improve the analytic capacity at the regional level. And we have some recommendations to how increase the policy relevance of the data coming out of the system. And one of the challenges is you get changes of people working at a country level. So we certainly recommended that there should be 2 focal points in the countries, and because to keep it going if someone moves to another department or dies. Unfortunately, we had one of our colleagues die of malaria. So almost finished. What was the influence of the Sekendo system and the regional, the Sendu system? What was the influence? Certainly, we presented at AU expert meetings in Addis Ababa in 2010. We also used the system to help train people in Nigeria to set up a similar system. We also provided training to the West African Epidemiology Network. We've provided technical support coming out of this to Senegal, to the Pan-African Drug Epidemiology Network. And we also, as I said, submit country reports annually to as South Africa to the African Union. Reflections on building such networks. I think certainly you need regional and national support. There is a need for some funding. We didn't find the network that expensive, but bringing people together 6 monthly or at least annually, I think would be key if you're developing a regional network. Ideally, these projects go from being just a project to a program that is embedded within and supported by government departments rather than as a research project, which was how the Sendu system first started out. You need champions to drive this at country and regional levels. There are boilerplates, which I think can be useful in helping countries get on board if there's any appetite to rolling this out again. One should have a small win strategy. As I said, be flexible, steadily improve it, and improve data collection, improve data validity, improve analysis and reporting over time. And that can happen when you have 6 monthly meetings and bring people together. And I've come from the 2.1 working group West just now, and I think one needs to increase compatibility with national and international reporting systems to reduce duplication. So that's it. Thank you very much for your attention.